Good afternoon. Today I'll be presenting a CNS case. Presenting Mr. R. He was an 18-year-old 10th grade student from Bhutan. He had presented with the following complaints: decreased facial expressions noticed for 8 years, thinning of both the upper and lower limbs for 6 years, weakness of both upper and lower limbs for 6 years, and inability to lift his right foot for the last 3 years. Uh, Coming to the history of the presenting illness, he was apparently well until 8 years ago when his relatives noticed that he had decreased facial expressions. Although he felt the emotions and there were audible sounds of the same, he was not able to smile or laugh completely. However, there was no spillage of food while eating, there was no deviation of mouth to one side, and he was able to shut his eyes completely. He also noticed that 6 years ago that there were thinning of his all four of his limbs. It was gradually progressive. He initially noticed them in both his arms, followed by forearms, then thighs and legs. He also noticed that his rib cage was more prominent, and this has slowly worsened over the last 6 years. 6 years ago, he also noticed that there was weakness of his arms. It initially started over his left arm and gradually progressed to his right arm over a course of 3 years. He noticed that there was difficulty in lifting his arms above the head. There was difficulty in reaching for objects that were kept in higher places. And there was also difficulty in combing his hair. For the last 3 years, he also had to support his elbow with the other hand when he had to eat. However, he was able to open and close bottle caps or lift cups from the table. He was also able to tear rotis while eating. There was no difficulty in mixing food, no difficulty in buttoning or unbuttoning his shirt. And he also felt that there was heaviness of the limbs. 3 years later, he noticed that there was weakness of his lower limbs also in the form of difficulty in walking and running fast. He also felt that his limbs were heavy. He was, however, able to get up from squatting position. He was able to climb and up and down the stairs without any support. He was able to grip chappals while walking, and there was no slippage of footwear. He also noticed that there was a drop in his right foot and that he had to lift his right leg high to clear the ground. He did not notice any buckling of the knees or tripping over objects or difficulty in walking over uneven surfaces. There was also difficulty of getting up from the lying position for the last 3 years. He required turning to one side and he had to support himself with his arms in doing so. They did not notice any head lag. There was no difficulty in breathing. There was no difficulty in there was no diurnal variation of the symptoms. There was no worsening with cold or exercise. And he also did not have any pain over the limbs. He did not have complaints of any cramps. They did not notice any tremors of the muscle. And he also did not notice any darkening of urine. He's a right-handed gentleman. He has average scholastic performance. There was no history of any decreased responsiveness, emotional ability, or speech disturbances noticed by the family. Historically, he also did not complain of any decreased smell. There was no blurring of vision, bumping into objects. There was no history of any double vision, drooping of eyelids, or any squint noticed by the patient himself or the relatives. He was able to perceive hot and cold water and pain over his face. There was no decreased hearing or any ringing sound in the ear. There was no difficulty in swallowing food, history of cough while eating, or any voice change. There was no difficulty in turning his head from side to side, and there was no difficulty in articulating words or chewing food. He was able to appreciate clothes over his body and perceive mosquito bites. He was able to differentiate between hot and cold water while having bath, and he did not complain of any numbness, tingling sensation, pins or needle sensation, or any burning sensation over his limbs. And there was no swaying or imbalance while walking. He had normal bowel or bladder habits, and there was no history of any constipation. There was no difficulty in breathing. He did not have any palpitations, lower limb swelling, breathlessness on exertion, or any history of syncope in the past, and there was no history of seizures. There was no history of any steroid use or CAM intake. He did not have any history of skin rashes, oral ulcers, fever, photosensitivity, and there was no high-risk behavior. Past history, he did not have any comorbidities. There was no history of any previous admissions or past surgeries. Birth history, he was born to non-consanguineous parents. He had normal delivery at term in the hospital, and there was no history of any nursery admissions. He had normal development till 12 years of age, and he had average scholastic performance. Personal history, there was no history of any allergies, no smoking, alcohol, or any drug abuse, and he had normal bowel and bladder habits. This is his family tree. He's born to non-consanguineous parents, and he's the eldest child. He's 18 years old. He has two sisters who are 14 and 4 years. And there was no history of similar illness in his parents, that generation, or the previous generation. Coming to the summary of the history, he's an 18 years old gentleman who had presented with insidious onset and slowly progressive weakness and wasting of bilateral proximal muscles of the upper limb and distal lower limb with bilateral facial muscle involvement. So my localization, it is a pure motor syndrome. I would like to localize it to the muscle.
So what is the total duration of symptoms, Tefila?
6 years.
6 years. So, and the symptoms started where?
It started initially started in the facial muscles. They noticed decreased expressions of over the face.
Sure. And then progressed on to the
Weakness and wasting of the limbs.
yeah, and weakness of the shoulder, you said, right?
Shoulder.
And he had proximal muscle weakness of the shoulder. And the difficulty that he developed in the lower limb was?
He was unable to clear his right foot. He had to lift his right foot above the ground. And he also noticed some difficulty while walking fast. But there was no history of any proximal muscle symptoms. There was no history of getting up from squatting position, climbing upstairs. He did not have to lift his foot.
So his weakness was mainly in the distal part of the lower limb. And you are saying that your localization is to the muscle. Okay, can you defend that, why you're thinking that the muscle is affected?
So it's a pure motor syndrome. So the localization can be from the anterior horn cells, the root plexus, nerves, motor nerves, or it can be the neuromuscular junction or the muscles.
Sure.
So anterior horn cells, he does not have any history of fasciculations, any cramps. There was in neuromuscular junction also, there will be history of fatigability, diurnal variation, which he did not have. And also, since it involved, there's a classical pattern where there is proximal muscle involvement that is more classically seen, and symmetrical involvement that is seen in muscles. And there is a classical pattern where there is proximal upper limb involvement and distal lower limb involvement. So it is fitting into muscle pathology. Nerves also can have sensory involvement or autonomic, but there are also pure motor syndromes which can resemble this.
Okay, so you're saying that he doesn't have features of anterior horn cell disease. He doesn't have features of a like a neuromuscular junction problem, and therefore you're thinking it's more, and the very long history. Now, when a person comes with a myopathy, right, a disease of the muscle, what are the characteristic symptomatologies associated with that?
Muscle, one thing is there's proximal more than distal weakness. It's usually symmetrical. And it's usually not associated with pain unless it's an inflammatory pathology. Examination-wise, there is usually the muscle bulk will be preserved unless it's atrophied in the end. Reflexes are also preserved unless there is atrophy. So,
can you list some of the common diseases which affect muscles and also then say how they present?
So one group will be the inherited or the muscular dystrophies. So
that's what your list, you have a lot of diseases of the inherited diseases, the dystrophies. Yeah.
So they have a classical pattern. They can present either with pure proximal muscle weakness or distal muscle weakness, or they have proximal upper limb and distal lower limb, or they have distal upper limb and proximal lower limb. They can have axial muscle involvement or present with head lag. And they can also, some muscular problems or muscular dystrophies also involve the cranial nerves. So that is one group. Then there are congenital muscular dystrophy, congenital myopathies.
So what are historically, what are the classical features of a dystrophy on the history?
Dystrophy depends on each type of dystrophy. They're usually not present at birth. They can present either during childhood or adolescence, and they can they're slowly progressive. And
so the course of illness is over many
Yes.
years, right? So long, very long period of time. And what are the other symptoms associated with it?
One thing, they can have atrophy. Some specific muscular dystrophies can have pseudo-hypertrophy. They can involve the cardiac muscles. Some can involve certain cranial nerves also.
And what about the family history?
Family history, certain diseases like FSHD are autosomal dominant. Limb girdle muscular dystrophies are autosomal recessive. Becker's DMD, they are X-linked.
So they may have a family history of consanguinity or family history of a similar kind of disease. So, what are the other pathologies which affect the muscle?
They can have inflammatory myopathies like polymyositis, dermatomyositis, inclusion body myositis.
So, what are the features of an inflammatory myositis?
They will have pain. And if there is like dermatomyositis, they can have classical skin lesions like the Scholz-Sign
The
V
dental
side.
profile?
It so it starts at a later age and it is more rapidly progressing.
Okay, so usually would you say it's acute or subacute or chronic?
Subacute.
So it's a subacute profile of illness, and you mentioned the point of the pain being a sign of inflammation within the muscle, and the groups of muscles affected in an inflammatory myositis.
Usually a limb girdle pattern, there is proximal muscle involvement. Exception would be an inclusion body myositis where there's distal.
And what are the other diseases which affect the muscle?
So they can have congenital myopathies. So they're usually present in birth and they're usually static. The diseases.
Very long history, but it's a non-progressive, and it starts at birth. Yes, go ahead.
Then there are mitochondrial myopathies. So there is maternal.
What are the acute diseases which affect the muscle?
One drug-induced
Can you
toxins.
name some of the drugs which are associated with the myopathy?
Glucocorticoids,
Yes.
statins.
Yeah.
AI.
Tell us something about the statin-induced myopathy.
Statin induced, it usually is an immune mediator, so they can have a antibody against the HMG CoA.
Yeah, but tell about the clinical presentation, not about the pathogenesis.
They present with proximal muscle weakness. So it is usually, it occurs after taking statins and even after.
So how soon after starting statins do you develop a statin-induced myopathy? So it's usually associated with high dose of statins, and it's very soon after the initiation of the statin therapy, and it's manifested by a pain. Okay, and often statins with fibric acid derivatives together can induce a picture of a toxin-induced myopathy, and can have associated profound weakness and so severe as to cause a rhabdomyolysis. But there's a long history of drugs that can cause a myopathy. But the main features of the acute nature of the what are other acute diseases which affect the muscle?
They can have rhabdomyolysis.
Yeah. Can you name some other conditions which cause acute muscle injury? Any other toxins you know? Yes. A snake bite can cause this. We know that viper bites can be associated with rhabdomyolysis. There can be myoglobinuria, acute renal failure. Yes. What other disease? Any other toxins you know which can cause muscle injury? What other diseases acutely can affect? Suppose a person complaining of fever with localized muscle pain, what diseases you'll think about?
Viral myositis.
Okay, some more. What are any bacterial processes which affect the muscle? Have you heard of the disease called the tropical pyomyositis due to Staphylococcus aureus? They tend to form localized inflammation, abscess formation. They affect the large muscles, particularly over the gluteal region, over the thigh, and then there is a trichinosis. Okay, trichinella spiralis can cause fever with severe muscle pain, profound eosinophilia, subconjunctival suffusion. So these are some of the acute processes. And then also we see it sometimes with heat stroke. with muscle injury. Neuroleptic malignant syndrome can cause muscle injury. So, what differentiates these different types from the infectious, toxic, the inflammatory, and the inherited types is very importantly the
Present.
temporal profile. And here, the very long history of illness makes us think that we are dealing with a degenerative muscle process and a dystrophy of the muscle. And the young onset tells you that this could be uh, inherited type of a myopathy, right? Uh, uh, Dr. Alex and Dr. Ajit, would you like to ask some questions and comment on the history?
Uh, yes, sir. Very nicely presented, sir. In addition to muscle diseases, even chronic neurogenic disorders can present with proximal predominant weakness. Like the prototype for that, this is just based on the history alone, not the examination findings. Like spinal muscular atrophy can also have some. The odd point in this case is very striking is that it started in the face, but it's a differential worth discussing in the when you discuss the localization. Chronic neurogenic diseases can also cause. The prototype will be like a spinal muscular atrophy. The other differential for very long standing weakness, which is proximal predominant, even genetic myasthenic syndromes can also present, like what you call the congenital myasthenic syndromes. Those are also close differentials for chronic myopathies and muscular dystrophies. Actually, they are one of the treatable diseases because they have good response to pyridostigmine, the usual cholinesterase inhibitors. So these two differentials also you can include in the while discussing at the level of the history. Then of course the examination findings like selectivity will help you to narrow down, as you rightly pointed out, that this is more likely to be a muscle than neurogenic pattern.
Alex?
Yes, sir. Tefila, that's a very nice presentation. Of course, I also agree with you that most probably it's a muscle disease. But I have a few questions on the history. You have said there is a kind of foot drop, but at the same time you said she is able to hold the chappals. Is it your history?
Did not have any history of slippage of footwear.
Right.
So
At the
which
same-
muscles you think are affected if a person able to grip the chappals,
Or
but still
interosseous.
not able to lift the foot off the ground, no?
The
Which-
tibialis anterior is involved for the dorsiflexion. If the interossea are affected, then the gripping of the chappals
So
will
there
be.
could be selective muscle involvement. May not be a completely a distal muscle weakness of all muscles, but could be selective involvement of the lower limb muscles.
Okay, yeah, that's right. Another important history which we could have taken is exposure to chemicals or drugs or heavy metals in this patient. Because these kind of people would have been exposed to multiple drugs, Ayurvedic and things like that, to start with the illness. So that is one history which you could have asked. The other thing, why did you ask the history of high colored urine? What is in your mind?
Some very rare causes like glycolytic pathway or fatty acid oxidation pathway can have myoglobinuria, or even for a long-standing case.
Okay, that is one. Sometimes, even porphyrias, they can present with motor neuropathies. So that's another thing which we can talk about. Yeah, that's all, sir.
Any other questions from the audience before we go on to the examination? I think you can proceed to examination.
The patient was alert, conscious, oriented to time, place, and person, and was not in any apparent distress. His BMI was 17.2 kg by meter square. His pulse rate was 84 beats per minute, regular, normal character volume. There was no radial or radiofemoral delay. His blood pressure was 126/84, measured over the right arm in supine position. His respiratory rate was 16 breaths per minute, and his temperature was 98 Fahrenheit. There was no pallor, icterus, clubbing, generalized lymphadenopathy, or pedal edema. Head-to-toe examination, there was a thoracic scoliosis that was present. He did not have any cataract, frontal baldness, hatchet facies, hypertelorism, or clinodactyly. There was no contractures noted. At the time of examination, we did not appreciate any fasciculations. There was no history of any hyperpigmentation of the skin, tongue hypertrophy, no Cushingoid habitus. There was no skin rashes, calf muscle hypertrophy. There was no low-lying posterior hairline. The neck head ratio was 1.7, and there was no neurocutaneous markers. Examination of the CNS system, higher mental functions. He was a right-handed gentleman. There was normal intelligence, comprehension, orientation, memory, immediate, recent, and remote memory was intact. Speech, the comprehension, fluency, repetition, naming, reading were normal. There was no emotional ability. Cranial nerve examination, go to the positive finding.
Positive finding.
The seventh nerve examination, there was loss of nasolabial folds. He could not blow out the cheeks, and there was no wrinkling of the foreheads, and also he could not tightly shut his eye on attempting to open it. And he was also not able to shrug his shoulders bilaterally. The rest of the cranial nerve examination was normal. Coming to the motor system examination, the attitude, the patient was examined in supine sitting as well as standing position. Examination-wise, we noticed a right foot drop. There was also flattening of the shoulders bilaterally. There was wasting of the paraspinal neck muscles, pectoralis major, trapezius, deltoid, biceps, hypothenar eminences, hip adductors, hamstrings, and tibialis anterior.
You put up a photograph. You want to just
Video.
say what are the findings on this photograph? What are the, on inspection, what are the things you see?
The most prominent thing that we see is a winging of the scapula, where there is prominence of the medial border of the scapula.
But here we
that-
notice that
it's
it's
more
there
on the
only on
right
one side, right? It's an asymmetrical winging. What other findings are there?
There is wasting of the paraspinal muscle. There is flattening of the shoulders. And
Which are the muscles of the shoulder which are affected? on
here,
inspection?
deltoid looks, it is wasted, but it looks overall preserved compared to the others.
Yeah. What
is
about the
easier.
the suprascapular muscles?
It's wasted.
It's grossly wasted. And there is also appears to be some neck muscle weakness. The skin,
There is some hyperpigmentation present over the skin.
sure. Go ahead.
And he also had an exaggerated lumbar lordosis. Bulk, it was symmetrical. Both his arms, forearms, thighs, and calves were equal on both sides. And tone of the limbs, both upper and lower limbs, had decreased tone.
Was there wasting in the lower limb?
There was wasting.
Where was the wasting in the lower
It
limb?
was present in the leg, leg as well as the thighs, the hip adductors and tibialis anterior, the anterior part of the leg.
Okay.
Coming to the motor power examination, his neck muscles were good. At the shoulder joint, his abduction, adduction, flexion, extension, internal rotation, as well as external rotation were 2/5.
So he couldn't lift his arms above the shoulder.
Without support.
So he had a grade 2 power. All the muscles of the shoulder were grade 2. Yeah.
At the elbow joint, the flexors had 2/power power, and the extensors had 3/5 power. At the wrist joint, the flexion extension were 5/5, and also the extensors and flexors of the fingers were 5/5. On the left side, we also noticed that he had a palmar interosseous weakness. He was not able to do the card test. The remaining intrinsic muscle of the hands the muscles were normal.
So the weakness corresponded to the areas of wasting.
Yes.
And were there any contractures that were noted?
No contract.
Okay.
Examination, the power of the lower limb. At the hip joint, the flexion, extension, abduction, and adduction was 4/5. At the knee joint, the flexion was 4/5, extension was 5/5. At the ankle, on the right side, he had a foot drop. So his the dorsiflexion was only 1/5. and the remaining was 3 by 5. And also he was not able to extend his great toe and the digits also. At the subtalar joint, the inversion was 2 by 5 and 3 by 5 respectively. And the intrinsic muscles of the foot, he was 3 by 5. So this is just demonstrating that he is able to get up from the squatting position. We also look for action and percussion myotonia, which is absent.
So how do you check for that? The action and percussion myotonia?
Action myotonia is we ask the patient to grip our hands and ask them to release. So if there is a slow release, then it's an action myotonia. Percussion is we percuss the thenar eminence, and there's also tongue percussion.
And when you percuss, what are you looking for?
Slow contraction and slow relaxation.
Relaxation. These are findings of a
Myotonic dystrophy.
myotonic disorders and myotonic dystrophy. Okay.
Sensory examination was all normal in all the modalities: the touch, pain, temperature, vibration, and joint position sense. Reflexes, in our patient, we had absent reflexes in everything except the knee, which was diminished, 1+. And plantars were flexors. The cerebellar examination was all normal. And spine examination, he had a thoracic scoliosis and there was no tenderness. Gait, we noticed that he had a high stepping gait on this right side, and there was also mild waddling. The rest of the systemic examination was fairly normal.
Can you just come back to that gate? Just play the. So the foot drop on the right side, more than a high stepping gait. Where do you get a high stepping gait?
Two things: if there's a sensory problem, as well as
What kind of sensory problem?
if they're not able to if there's a joint proprioception.
Proprioception problem. Where do you get severe proprioception problems?
Posterior column involvement can happen in vitamin B12 deficiencies, tabes dorsalis.
Yeah, and large fiber neuropathies. So here the features are not so much like a high stepping gait with a posterior column problem, but rather that there is a weakness of the dorsiflexors or there's a foot drop on the right side. Yeah, proceed.
The rest of the systemic examination was normal. So summarizing, he's an 18-year-old gentleman who presented with insidious onset and slowly progressive weakness and wasting of bilateral proximal upper limb muscles and distal lower limb muscles with bilateral facial muscle involvement. On examination, there was thoracic scoliosis, there was wasting of the proximal upper limb and again distal lower limb muscles, there was bringing of scapula present, there was bilateral facial muscle weakness, and with a right foot drop. So again, localization after the end of examination and history, again, I would like to...
So I think that Dr. Ajit has brought up the issue of we always have to keep in mind that there could be a motor neuron disease like a spinal muscle atrophy or a young onset myasthenic syndromes. So here, is there anything on your clinical examination which makes you think it could not be the muscle, or is there any finding on your examination which contradicts your diagnosis?
One thing is there was absence of reflexes.
Can you just comment on that? Yeah, what does the absence of reflexes mean here?
One thing is it's a long-standing muscle. There's atrophy and the power is only 2 by 5, so that can be present.
So usually, what are the reflex findings in a myopathy?
Usually it is normal.
Okay, so the reflexes are preserved. And why is that?
Because there is no...
so the reflex arc is preserved. So the degeneration is in the muscle fiber. So your reflexes should be present. When in a myopathy, are reflexes absent? or grossly diminished?
It's a long-standing
Yeah, if the muscle is completely
atrophy.
wasted and the muscle cannot initiate a contraction, only in such a situation will the reflexes be absent. So you really have to have a grossly wasted muscle before you have an absence of reflexes. So here, like you're saying that the quadriceps muscle power is good, right?
It's 4.
Yeah, but your knee jerk is absent. He can walk, but your ankle jerk is absent. So here, the question is that is there some associated uh, involvement of the reflex arc is one question did you look for features of a myasthenic syndrome? How will you assess for a myasthenic syndrome?
One is there'll be fatigability. So we can ask the patient to lift the arm or look upward, and there will be drooping of the eyelids, or there'll be fatigability. So he did not have that.
And similarly, you asked for hand raising as well.
Getting up from squatting position multiple times.
Sure, you checked for that.
Mm.
Okay. And what other findings you look for in a patient you're suspecting a muscle dystrophy? You mentioned some associated findings. But did you look for those? You mentioned something about pseudo hypertrophy, right? Where do you look for that in pseudo hypertrophy?
So in a case of Duchenne's muscular dystrophy or Becker's, we look for calf muscle hypertrophy. He did not have that. He had wasting.
Sure. Dr. Ajit?
So exactly, sir. Like regarding the reflexes being absent, and second thing, the foot drop also is quite asymmetric. Foot drop also is a odd finding which we have to discuss in the context of a. If we are discussing, most of it is facial and proximal weakness, but why the right foot drop? One way to explain is like a primary working diagnosis is like a facioscapulohumeral dystrophy, which is the muscular dystrophy, which is the prototype of a muscular dystrophy which has asymmetric involvement. Like you showed the scapula winging is asymmetric, so that is the prototype. They can also have foot drop. They can also have severe axial and paraspinal weakness. The foot drop also can be asymmetric, but again, when we discuss in the context of a myopathy, asymmetric foot drop will be meaning usually more for a neurogenic pattern than a muscle, though FSHD is an exception which can present like this. So as exactly as sir mentioned, like the reflexes being absent and the right foot drop are little red herrings in the case.
Alex, yeah.
I think you have covered most of the things. Did you look for any nerve thickening in these patients? Because you haven't mentioned, I guess.
I didn't.
Okay. So which disease you are thinking of if there is nerve thickening?
Leprosy, amyloid, Hansen's disease, and amyloid.
Any other hereditary diseases? Okay, all these HMSN, no, hereditary motor sensory neuropathies. So we should carefully look for nerve thickening. Usually they have sensory symptoms also, but there can be pure motor symptoms as well, some of the things. So that is one thing which is. So what is called the Ellsberg phenomenon?
Sorry, sir?
What is
Ellsberg
Ellsberg phenomenon?
Ellsberg phenomenon is usually seen in high cervical cord lesion, where there is a U-shaped pattern of involvement. So if there's left upper limb, then there's left lower limb involvement, right lower limb, and right upper limb involvement.
So here there is no pattern like that, isn't it?
No.
Okay. Yes. Yes, sir. Thank you.
We'll just go to your diagnosis. So you've put a lot of differential diagnosis of a possible dystrophy, right? And can you tell us why you're considering a facioscapulohumeral dystrophy? You put LGMD. Tell us the full forms of that. And why are you not considering more common forms of dystrophy like Becker's type of. So could you just explain the clinical features of the common dystrophies and why you're thinking of a facioscapulohumeral dystrophy?
Facioscapulohumeral dystrophy, because classically of the phenotype, there was facial muscle involvement that precedes the limb involvement. And in upper limbs, it's usually proximal muscles that are involved. And lower limbs, it is
So in the upper limbs, which are the muscles involved in a facioscapulohumeral dystrophy?
usually the trapezius, usually deltoid is spare more than the biceps or the triceps.
So this is the deltoid sparing. And the other point which Ajit mentioned was it the asymmetrical pattern of the involvement. First the face and then the shoulder. Which are the upper limb muscles that are affected?
Um, the shoulder flexors, extensors,
So
abductors.
the arm
muscle.
muscles and even the forearm muscles can be affected. Another feature is the presence of contractures can be there in a facioscapulohumeral dystrophy. So you said that the progression from the face to the shoulder and then to the lower limb, right? And in the lower limb, which are the muscles affected in a facioscapulohumeral?
Usually the distal muscles, and they can have foot drops.
So what are the the time onset of a facioscapulohumeral dystrophy?
It's usually adolescent onset, and it's
This sort of fits in with a adolescent onset. It's not a childhood onset, and it's coming in adolescent. And what is the progression in a facioscapulohumeral dystrophy?
It's usually very slow, and they have normal, almost near normal lifespan. They don't have involvement of the cardiac muscles.
So they tend to be able to walk. But what are the other involvements other than the muscle in a facioscapulohumeral dystrophy? Are there any other nerves which are affected? Cranial nerves?
You can have neck muscle, cranial nerves.
Yeah. Can the eighth nerve be involved?
Yeah, eighth nerve can be
So you
involved.
can have
Hearing.
deafness and the vision.
They can have something called Coates syndrome, where they can have retinal detachment, exudates, and telangiectasias.
Yeah, so vascular involvement of the retina so can be there. So he doesn't seem to have those. How will you differentiate this from Becker's or a limb girdle or a oculopharyngeal?
Oculopharyngeal, they can have ocular muscles that are involved. They can have both ptosis as well as the ocular muscles, and they can have pharyngeal involvement also. So bulbar muscles will be involved. From Becker's and Duchenne's, Becker's, it's again a limb girdle pattern of weakness. Becker starts in adolescence, Duchenne starts
So which
like
are the
earlier.
muscles which are affected first in a Becker's and Duchenne's?
Both proximal, upper and lower limb.
So what are the earliest symptoms of Duchenne's?
They can have difficulty in getting up, like the lower limb, getting up from squatting position. They can have Goer's sign.
So the lower limb is affected
Affected
first before the upper limbs. And like you said, the difficulty in getting up, difficulty in going up the steps, and the Gowers sign being positive, and the pseudo hypertrophy. And what is the age of onset of a Becker's?
Becker's is like around 12 years, I think.
Similar, like an adolescent pattern. How does it progress?
It is faster than a FSHD, but slower than a Duchenne. So
Progresses into the adulthood is where it becomes very
40 years.
severe and people become wheelchair dependent. What are the other associations of Duchenne's and Becker's?
They can have intellectual disability. They can have cardiac involvement.
So what are the cardiac problems associated with the Becker's?
They can have cardiomyopathy, so they can have progress to heart failures.
Heart failures and
Conduction
block. So death due to sudden cardiac death is one of the problems with the limb girdle. How does it differ?
Limb girdle, there are many types. There's autosomal dominant and autosomal recessive. So each has different patterns, but usually they're proximal upper and lower limb. They don't have facial muscle involvement.
Okay, so here this is not like a limb girdle. It's not like a Becker's type. And here we can see that he's walked, and it's predominantly the upper limb and the distal lower limb. Okay. So how do you how will you proceed to try and find out, is it truly a muscle dystrophy, and what type of muscle dystrophy it is?
The investigations wise, first we would do a CPK. In a dystrophy can be elevated.
What is his CPK?
Creatinine phosphokinase,
yeah.
muscle enzyme.
What is it? What is his level?
Oh, his level 904.
So what does that tell you?
So it is a muscle pathology that is involved. It's not too high for it to be to think of other causes like a rhabdomyolysis, endocrine like hypothyroidism, but it's fitting into a dystrophy.
Okay, so it doesn't tell you it's a dystrophy, but it tells you that it is one of the features. When does the in a dystrophy, when does the CPK go up? Which phase of the dystrophy? So it's early on in the dystrophy when the muscle is still getting injured. But in very advanced phases, actually the CPK may come down to almost normal. So here tells us that still the disease is actually evolving. Okay, and what other tests are required?
We have to rule out other causes like endocrine, not in his case, but generally. So we do a TSH, calcium levels, phosphate, vitamin D levels. That is one. And
ECGs were done in him?
ECGs were done. It was normal.
Normal, okay.
Then we also can do EMG, EMG NCS.
Necessary for the diagnosis, right? Yes. Yeah. So what are the findings we look for in the EMG?
For him, it was so one thing is we have to rule out any muscle pathology or a motor neuron disease. So that will be seen. So there won't be any NCS should be normal in them. And if it's a inflammatory or inflammatory myopathy on insertion of the needle, there will be irritation.
Comments, Alex?
Regarding the EMG, sir?
Yeah, I just also the EMG findings, Ajit, and the investigations.
Ajit, you are answering?
Sorry, I was muted. No, the needle EMG part of the electrophysiology report is there, Tefila?
It's on or it's already on the screen.
So no, sir. It's only the conduction which is mentioned, sir. That's what I was saying. So the needle EMG part also, one more line might be there. So this motor axonopathy can be seen in muscle diseases also, sir. Like the CMAPs being reduced specifically, that can be seen in both muscle and neurogenic disorders. The needle EMG gives an idea whether it's because of a myopathy or a neuropathy. And facioscapulohumeral dystrophy is one of those muscle diseases where you can have mixed neurogenic and myopathic changes also. It's one of the differentials for muscle diseases which can have neurogenic changes also, sir.
Ajit, how do for all of us who are on the thing,
Yes, sir.
how do we approach the management of patients with muscle dystrophy? Could you just update us on?
Yes, sir. Yes, sir. So, yes, sir. First, most likely, if you're dealing with a genetic or inherited muscular dystrophy, apart from the phenotyping, which Tefila discussed, the age of onset of Duchenne, of Becker, and limb girdle muscular dystrophy, these are the common kinds of muscular dystrophies which can be seen. The commonest muscular dystrophy in all age groups put together is myotonic dystrophy. and FSHD also comes a close second. So these are the commonest type of muscular dystrophies which are seen. All of them have a typical, meaning all are chronic illnesses, but they do have a specific pattern of muscle selectivity which can be seen. In terms of so phenotyping will be important depending on the age of onset, the family history, anybody, whether it's X-linked or it is autosomal recessive. The limb girdle muscular dystrophies, what we commonly see in clinical practices are autosomal recessive. So it's very likely that there could be a sibling who's affected. So we will have to carefully ask for history. Whereas for either Becker or Duchenne muscular dystrophy, because they are X-linked, usually you can get the history that the maternal uncle is affected or any other male sibling is affected. That's a common history we get. In terms of examination, CPK gives a good clue. Like Duchenne muscular dystrophy usually has CPK in, like you mentioned, sir, like in the early inflammatory phase, it can be very high, even going up to 10,000, 20,000, 30,000. And as the child becomes non-ambulant by 9 or 10 years of age, the CPK starts declining. Becker's usually has CPKs just around between 800 to 1200, maximum 2000. The limb girdle muscular dystrophies also tend to have, again, it's a differential pattern. So like sarcoglycan can have very high CPKs, whereas the common autosomal recessive limb girdle muscular dystrophies have it around 1000 to 2000. So each phenotype is, so CPK being elevated, the next test of choice will be to do the nerve conduction and EMG. So the needle EMG needs to be done from a specific muscles, like the common muscles which we needle are the involved muscles, the proximal muscles which are weak, like either the deltoid biceps or the quadriceps and the tibialis anterior also in some cases. We look for, meaning more than the spontaneous activity, we look at when the patient is trying to put in a volitional effort, what is the morphology of the motor units which are produced. So typical myopathy has motor units which are very small amplitude, and because the muscle is weak, with a very small effort, a lot of motor units get recruited. So just for the sake of theory and exams, the two patterns which are seen in a needle EMG study in a muscle disease are, one is the presence of a very small motor unit potential, and second is a early recruitment or complete interference. So these are the two findings which we see in a needle EMG test. As Stefla is showing the slide, the next pattern will be to, previously it was a muscle biopsy, but now with more and more advent of genetic testing, the next step in the algorithm is to go ahead with a genetic testing. The genetic testing depends on what phenotype you're suspecting, because each type of muscle disease has a particular genetic testing strategy. Like if you see, that depends on the genetic basis of disease. Like if you see a patient with Duchenne muscular dystrophy or a dystrophinopathy, the commonest genetic defect responsible for a dystrophinopathy is a gene deletion or duplication, usually a gene deletion. Whereas for some other diseases like limb girdle muscular dystrophy, it's usually a point mutation or what we call a missense variant. So genetic testing strategy differs. In the context of FSHD, the genetic testing is different in comparison to all the other genetic testing strategies, because it is actually one of the very few, one of the unique diseases across the whole spectrum of genetic disorders which doesn't pick up on the routine genetic testing. So you need some advanced testing which is very expensive, which is known as optical genome sequencing, OGS we call it. So genetic testing, and of course muscle biopsy. The next question will be, what are the findings suggestive of myopathy in a muscle biopsy? Like, because we also discussed that spinal muscular atrophy can also cause a similar pattern, like a proximal predominant muscle weakness. Actually, spinal muscular atrophy is also known as a pseudomyopathic pattern of muscle weakness. So the characteristic findings on muscle biopsy in a patient with myopathy will be like, usually the muscle fibers are very polygonally shaped, so there'll be rounding, loss of that polygonal shape, there will be internalization of nuclei, there'll be a lot of fibrosis, there might be some inflammation. So those are myopathic features. Whereas like grouping of multiple muscle fibers means that the the nerve supply to the muscle fiber is lost. So that's what we call as group atrophy, which is more specific for a neurogenic pattern. So commonly, and of course, the ancillary investigations like a ECG and a echocardiogram give us indirect evidence of a pattern of cardiac involvement, which is seen in a lot of muscular dystrophies, including FSHD, as well as FSHD can have arrhythmias, as Tefila rightly told, and similarly, Duchenne, etc., have cardiomyopathy. So the main investigations, in addition to having a proper phenotype, is to do a CPK, EMG studies, and a targeted gene testing. And of late, we have this genetic testing panels are there, in which if you suspect like a proximal muscular dystrophy, they customize the panel in such a way that all the common causes of muscular dystrophy are tested by the panel. So the safest answer to tell for a genetic testing strategy will be a targeted disease-based panel for a inherited myopathy.
You update also on the genetic therapies, and what do we offer when we see patients with a inherited muscle disease? How do we discuss the issue of therapy and options?
Yes, sir. That has an ethical aspect also to it, sir, because of the availability of therapies. So again, there are few muscle diseases in which therapies are available, like Duchenne muscular dystrophy, due to around 15 to 20% or even lesser of the Duchenne muscular dystrophies actually have genetic defects which are amenable to therapy. Like those are again based on what is the defect, which chromosome. So you have something called as out of frame and in frame mutation. So the basic concept of gene therapy in a Duchenne muscular dystrophy will be to override the genetic defect to make the patient's phenotype a milder phenotype. So what we tell in teaching is the patient with a Duchenne muscular dystrophy is a child who might stop walking at around 10 years of age. They get converted to like a child or patient with a phenotype like a Becker muscular dystrophy, in which they'll be walking later into adulthood also. So that's a common concept of genetic therapy in Duchenne muscular dystrophy. And it is so the technique which is used for gene therapy in Duchenne muscular dystrophy is something known as exon skipping. Suppose a patient has deletion of exon 45, 51, or 53, that exon can be skipped because the usual, we all know the DNA, the gene is part of the DNA. The DNA gets transcribed to an RNA. The RNA gets translated to a protein. So eventually it is the dysfunctional protein which is at fault for the muscle fibrosis. So the basic, it is like a targeting the cause itself, like the gene, if it's deleted, you're trying to override the genes in such a way that somehow the mRNA and protein are formed. So that is the name of exon skipping strategy. There are a couple of 3 exons which have been approved by the FDA for treatment outside clinical trials based on some results in the clinical trials. But how early you need to start it, still people do believe that if you, meaning if you have to really have a maximal benefit, you might have to start it much more earlier in patients who are having very minimal problems, because once they become non-ambulant, none of the trials have shown benefit in these children. So that is the main gene therapy available in muscular dystrophies. In all the other muscular dystrophies, we don't have any approved genetic therapies, including FSHD, because FSHD, as we mentioned, like has a unique genetic abnormality. So it is one of the things which have been worked on, because the gene, the cause is one of the genes, what you call as DUX4 being overexpressed. So that is one target which is being studied right now, but nothing yet which is approved or which is coming on for treatment. Of course, one major part of the treatment is to rehabilitate the patient in terms of avoiding contractures, keeping the doing submaximal exercises for the muscles to keep them flexible, to maintain ambulation till maximum possible, to concurrently take care of the bone health also, because they are likely to develop vitamin D deficiencies or osteoporosis. So bone health maintenance is also very important. And of course, like because they're at risk of cardiomyopathies and cardiac arrhythmias, so that also needs to be looked at. One more thing which usually is done in myopathies is to look at the respiratory muscles also, especially if they have symptoms like orthopnea. They might need a ABG, because some advanced muscular dystrophies can also need some respiratory support later in life.
You mentioned some ethical issues, Ajit. What
Yes, sir.
clarify on that?
Yes, sir. So ethical issues with regards to treatment in muscular dystrophy is one, the availability of medicine and the availability of medicine outside the scope of clinical trials, which is a major problem, because till around 3-4 years ago we didn't have gene therapies being tried out in India also, and it forms just a small cohort of patients who are amenable to treatment with gene therapies. The ethical issues are more in terms of these everything, including Duchenne muscular dystrophy and spinal muscular atrophy, are very rare diseases. But as you all know, one of the costliest gene therapies which has been approved is for treatment of spinal muscular atrophy, which is it is a gene replacement therapy, almost coming to a single course coming to around 16 to 18 crores in Indian lakh rupees. So, and there are a lot of children with spinal muscular atrophy in India also at various ages, who and in contrast to Duchenne muscular dystrophy, the therapy in spinal muscular atrophy has been shown to be effective also. Meaning infants who might die by 6 months of age actually gain their milestones also and start sitting without support. So that's the evidence which is there. So there are like public-private partnerships to try to get these medicines into the market, but they are very expensive. So right now, what is being followed is something known as crowdfunding campaigns for people who are not able to afford the medicine. So they go via social media, try to form groups in which, meaning they get pooling of money from different sources, like even including NGOs, which help them support. But how long it will be able to sustain is a matter of problem. So those are the ethical issues, like in terms of how to get the medicine so that everybody has access to the medicine.
So access, and I think there are some cases in the court also to
Yes,
make
sir. Yes,
the SMA
yes,
medicines
Ye-
available.
yes, sir. So what is being highlighted in the court is that some of these medicines, the cost actually, if you manufacture in the country itself, actually might come out to be much less cheaper than what is being sold by the pharmacies the abroad. So that's one thing which is there. Why can't you manufacture in India itself so that the costs come down? Yes, sir.
Thank you for sharing that. So how, I mean, in the light of all the points that you mentioned, that
Yes,
actually
sir.
treatment is most often not easily available because of the high
Yes.
cost.
Yes, sir.
How important is genetic testing when we see a patient in our clinic?
Yes, sir. Yes, sir.
How much should we push for it?
So we would be in favor of pushing for it. One is because one, to have a definitive diagnosis. The second, in terms of a prospective genetic counseling for the family members also, because one thing which is advanced in genetics and which we do have even in our institute and all over places in India is prenatal diagnosis. Like suppose this gentleman or a sister or anybody is going ahead with a marriage, even uh, you can have a concept of prenatal diagnosis when you have a definitive genetic test. So that is one main advantage. And of course, one thing which we even experienced with the Duchenne muscular dystrophy is that, like unless you have databases of specific diseases and specific disorders, whenever gene therapies come into place, also they usually come in via clinical trials. So unless you have genetic diagnosis, they may not be eligible for participation for any clinical trials. And fourth, of course, is like you can have mimics. Like even this patient something like if patient turns out to have something like a congenital myasthenic syndrome, those actually are they respond very well to drugs like salbutamol or pyridostigmine. So it is a common mimic of a limb girdle syndrome. So those kind of diseases might be amenable to very cheaper therapies. So those are the advantages of doing a genetic testing. And of late, the genetic testing is actually not very costly. Meaning there are panels which come for around 7 to 11,000 also, which because of it being extensively used. So and that's why it is always good to have a genetic test if possible. So
Thank you very much, Ajit, for
okay, sir.
explaining all this.
Yes, sir.
If there are, can we have a few minutes for any questions that are coming from the audience on any aspect of the presentation discussion so far? You can either type it in or unmute and speak. Any final comments, Alex and Ajit, before we wind up?
It was a great presentation, actually. So, a lot of things have been covered, and I think it is most probably it's like a facioscapulohumeral muscular dystrophy. So, and a lot of good discussions we had, and especially here to thank Rajit for that. So, so I also really enjoyed. Thank you very much. Thanks, Tafila. All the best.
Ajit, any feedback to?
Yes, excellent presentations. Like I think we discussed a lot of things out of meaning which may not be exactly required from a teaching perspective, but I think it's fantastic case presentations.
Yeah. Thank you everyone for joining today, and let's give a hand to Tafila for excellent presentation, and also the Dr. Ajit and Dr. Alex for joining us today and for having a good discussion. Have a good day to you.
Thank you, sir.
Thank you, sir. Thank
Hexagon team, you can end the meeting. Thank you.